I want to start today with a patient scenario. And I don't mean one of those rare, House MD style mysteries.
Right, not a once-in-a-career thing.
No, not at all. I mean a scenario that really plays out in clinics and GP offices every single day, all over the world. It's a quiet mystery, but if you miss it, the consequences are just
It
devastating.
really is a classic medical whodunit.
Yeah.
And the clues are all there, but they are incredibly subtle.
Exactly. So I want everyone listening to just picture this. You're in the clinic, the door opens, a 60-year-old patient walks in, they sit down, and they just look a little drained.
Not an agony.
No, not clutching their side, just
Hmm.
off. They tell you they've been feeling tired lately, maybe getting a bit winded when they carry groceries, or walk up the stairs. You run a standard blood panel, and the results come back with a very specific finding: iron deficiency anemia.
It's such a common finding on a lab report, right? Low hemoglobin, low MCV, it can feel like just another number on a page, really.
Right. And this is where the detective work begins. You look at this patient and you start digging for symptoms. You ask, does your stomach hurt?
And they say no.
They shake their head. No. Do you have cramps or bloating? No. Have you seen any blood in the toilet? No. Any change in your bowel movements at all? No.
And that silence,
Yeah.
that total lack of specific symptoms, that is the trap. That is where so many clinicians get reassured when they absolutely should not be.
So the challenge for everyone listening right now is this. Based on that profile, a 60-year-old with iron deficiency anemia and absolutely zero abdominal pain, where is the tumor? Because there is a tumor.
Just take a second. Visualize the anatomy of the abdomen. Trace the gut in your mind from start to finish.
If you didn't immediately scream right colon inside your head, then this deep dive is going to be absolutely essential for you, because that specific constellation anemia without pain is the signature. It's the calling card of a right-sided colon cancer.
And missing that signature is how diagnoses get delayed for months, sometimes even years. Because we're all waiting for pain. We're waiting for an alarm bell that isn't going to come until it's much, much too late. Today, we're going to make sure you never miss that pattern again.
Welcome to the deep dive. Today we are tackling lower GI oncology. This is the Masterclass. We are going downstream, starting from the colon, moving through the rectum, and we're going to end up at the anal canal.
And we're doing this with a very specific mission. I mean, lower GI oncology is massive. If you open a textbook, it's just hundreds of pages of trials, chemo regimens, surgical techniques. It can be so overwhelming.
For sure.
But our mission today isn't to memorize a textbook. It's to decode the anatomical patterns. We want to understand the logic of the body.
I love when we talk about the logic of the body because, usually cancer feels like chaos. It just feels like bad luck or, I don't know, genetic anarchy. But you're saying there are rules.
There are absolute rules. There are patterns that are dictated by anatomy, by embryology, and even by the physics of the gut. If you understand the why the anatomy is shaped the way it is, why the blood flows the way it does, then the symptoms, the treatments, the staging, it all becomes easy.
So it stops being memorization.
It stops being memorization. It starts becoming intuition.
And that is our promise to you today. We're going to give you the shortcut to that intuition. We'll structure this by moving anatomically downstream. So we'll start with what we're calling the tale of two colons, splitting the right from the left.
Then we'll get into the genetic blueprints, FAP versus Lynch syndrome.
Right. Then we'll break down the rules of engagement for staging. And finally, we'll finish with the rectum and anal canal, which is where the rules completely flip upside down.
And we will be highlighting the exam traps all along the way. Those common misconceptions that trip people up on board exams, and more importantly, in the clinic.
Let's jump right back to that 60-year-old patient and this tale of two colons. I think for a lot of people, and honestly, even for students early in their training, the colon is just the colon.
One big tube.
Yeah, it's one long tube that snakes around the belly. It looks like sausages linked together. Why should we treat the right side and the left side like they're two completely different organs?
Because biologically and clinically, they are different entities. Their embryological origin is different, their blood supply is different, and crucially for our discussion today, the environment inside them is completely different. And that environment dictates how a tumor grows and how it presents.
Okay, let's unpack the right side first.
Yeah.
This is our anemic patient. So we're talking about the ascending colon and the cecum. Why is this side the silent side? Why didn't our patient have any pain?
To understand the silence, you have to visualize the physics of the right colon. I mean, the right colon is the beginning of the large intestine. It connects right to the small intestine. And Anatomically, the diameter of the colon here is wide. It's a really spacious room. Specifically, the cecum is like this large distensible pouch.
Okay, so we've got a wide tube, a lot of real estate.
A ton of real estate. Now, think about the cargo. What's flowing into that room from the small intestine?
It's liquid, right?
It's liquid. It hasn't been processed into solid waste yet. It's basically a slurry.
So to summarize, we have a wide pipe and we have liquid contents flowing through it.
Correct. Now let's introduce the villain, the tumor. Tumors on the right side of the colon tend to have a very specific growth pattern. We call it exophytic.
Exophytic, that's a great word. Let's break that down for everyone.
Sure. Exo meaning out. So these tumors, they grow outward into the lumen, into that open space. They don't usually burrow in and cinch the wall shut right away. Instead, they grow like a cauliflower or a mushroom sprouting from the wall.
Okay, I have that visual. A cauliflower growing inside a wide pipe with a liquid slurry flowing past it.
Exactly. Now, does that cauliflower block the flow of the liquid?
No, probably not. I mean, the pipe is wide and the liquid just flows right around the obstruction.
Precisely. The liquid flows right past that cauliflower-like mass. And that is why you don't get obstruction. You don't get that stopped-up feeling. You don't get the cramping pain of a blockage.
The plumbing still works?
The plumbing still works. The patient eats, they digest, they use the bathroom, and everything seems completely normal mechanically.
Okay, that explains the lack of pain. That makes sense. But the patient is sick. They are anemic. So why? Where is all the blood going?
Because that cauliflower, that exophytic tumor, is incredibly fragile. It's vascular, it's growing fast, and it's what we call friable. It's easily irritated.
So as the stool passes by.
Even though it's liquid, it irritates the surface of the tumor. The tumor ulcerates, and it bleeds.
Is it a massive bleed, like a hemorrhage?
Almost never. It doesn't bleed like a cut artery where it gushes out. It just oozes. It's a slow, chronic, microscopic leak. We call it occult bleeding.
Occult, meaning hidden.
Yes. And think about why it's hidden. The blood drips into the liquid stool, way up in the right colon. By the time that stool travels all the way across the transverse colon down the left colon and sits in the rectum, that blood has been digested. It has been mixed in. It oxidizes. It becomes completely invisible to the naked eye.
So the patient flushes the toilet and sees normal-looking brown stool. They have no idea. They think everything is fine.
I think they're fine. But every single day, they are losing a teaspoon of blood, maybe a tablespoon. Day after day, week after week, they're losing iron.
And the body's reserves just can't keep up?
They can't. The iron stores deplete. The hemoglobin drops, and eventually the body just can't make enough red blood cells.
And that leads directly to the symptoms we saw in our patient. The fatigue, the shortness of breath on exertion, just feeling completely drained.
Exactly. They're running on empty because they are constantly leaking fuel, and they often lose weight because the cancer itself is a metabolic parasite. It's just consuming their energy.
Yeah.
But they never get that sharp, loud alarm bell of pain.
Which is terrifying, actually. It sounds like the trap here is that patients present so late because the symptoms are just incredibly vague.
They are.
They dismiss it. Oh, I'm just getting old. I'm just out of shape.
Correct. And that is why recognizing iron deficiency anemia in an older adult is a do-not-miss clinical sign. If you see iron deficiency anemia in a man or a postmenopausal woman, you absolutely cannot just give them iron pills and send them home.
You have to assume it's a GI bleed.
You must assume it's the GI bleed until proven otherwise. You have to go looking for the cauliflower.
Okay, so that is the right side pattern. Let's just lock it in. Right side appears wide tube plus liquid stool plus exophytic tumor, anemia, no pain.
Perfect.
Now, let's travel across the abdomen to the left side.
Right.
The descending colon and the sigmoid. How does the story change here?
The environment changes drastically. We are entering a totally different ecosystem. Anatomically, the left colon is much narrower. It's a tighter tube.
And the cargo. What's the stool like at this point?
Well, the primary job of the colon is to reabsorb water. So as the stool moves from right to left, all that water is being sucked out. By the time it reaches the descending colon and sigmoid, it's solid. It is formed stool.
So now we have a narrower pipe and we have a solid brick trying to get through it.
Exactly. And the tumor biology changes too. Instead of growing like a cauliflower out into the lumen, left-sided tumors tend to grow circumferentially.
Circumferentially. So like a ring.
Yes. Think of a napkin ring tightening around a napkin, or a zip tie tightening around a soft hose. The tumor grows around the wall of the colon, invading the entire circle and cinching it shut.
We call that the apple core lesion sometimes, right? On imaging.
Yes, on an X-ray or a CT scan, It looks just like an apple core because the middle has been eaten away and narrowed down. But the physical consequence of this is, of course, obstruction.
It's a straight-up mechanical blockage, a
Yeah,
plumbing problem.
it is. And this leads to a completely different set of symptoms. Because the pipe is getting squeezed shut, the patient will notice a change in their bowel habits. They might report constipation. They might report bloating or cramping pain as the gut tries to push against that blockage.
And this is where that classic description comes in.
Yes, the classic description you will hear is pencil-thin stools.
That is such a specific and alarming image. Pencil thin.
It's just physics. If you force soft clay through a tiny round hole, it comes out as a thin string. The solid stool is being squeezed through that tiny napkin ring opening created by the tumor.
And I imagine that friction, that squeezing, it causes other issues too.
Absolutely. Because you are forcing solid stool through a tight, cancerous, friable ring, there is friction. You get bleeding.
Right.
But unlike the right side, where the blood is old and mixed in and hidden, here the blood is fresh. It streaks the outside of the stool.
So the patient actually sees bright red blood.
They see it. And honestly, that frightens them, which is actually a good thing in a grim way, because it brings them to the doctor much earlier than the vague fatigue of the right side.
Pain and visible blood are powerful motivators.
They are.
So if we look at our elimination logic or our clinical decision tree here, it really simplifies things quite a bit.
Let's walk through that mental flow chart again.
Okay, if a case comes in and the main feature is anemia without any pain,
You can pretty much eliminate the left side. You have to think right colon.
and if the case is all about obstruction symptoms, cramping, visible blood, and these pencil-thin stools,
You eliminate the right side. Your mind should go directly to the left colon.
that is a really clean, powerful divide. It makes it much easier to visualize. Now, just to wrap up the basics of the colon before we get into the genetics, where are these things usually found? If you had to bet money on a location, what's the most common spot?
The most common site overall is the rectosigmoid junction, that area down on the left side where the sigmoid colon turns and dives down to become the rectum.
Okay, the rectosigmoid. And the type of cancer, I know there are lots of fancy names in oncology. Squamous, sarcoma, adeno. Well, what's the one to know here?
For the colon and the rectum, the vast majority are adenocarcinomas.
Oh.
Adeno means gland. The colon is lined with glands that make mucus to lubricate the stool.
Right.
When those glands go rogue, it's adenocarcinoma. That's the histology you really need to remember.
Got it. And one last thing on the general colon pattern metastasis. If this cancer decides to travel, where is it going first?
The liver. This is the liver connection. It is a critical high-yield point.
Okay, why the liver? Is it just bad luck? Proximity?
No, it's plumbing again. It all
Interesting.
comes back to the plumbing. Is the venous drainage, the blood flow from the colon doesn't go straight back to the general circulation.
It takes a detour.
It takes a detour. All that blood goes into the portal venous system, and the portal vein goes directly to the liver to be filtered.
So the liver is the first stop. It's the first filter that the blood from the gut hits.
It is the very first filter. So if a cancer cell breaks off from the tumoral wall and gets into the bloodstream, the liver is the first capillary net it's going to hit, and it gets stuck there. That is why liver metastases are so incredibly common in colon cancer.
Okay, so here's a scenario from our notes. A patient comes in, you find a mass in their sigmoid colon, and you also see multiple lesions, multiple spots in their liver on their scan. What's the thought process?
The logic should always be, this is metastasis from the colon to the liver.
It's not two separate cancers?
Do not assume the patient has two separate cancers.
Yep.
Do not assume it's a primary liver cancer. Primary liver cancer is actually quite rare compared to liver metastasis from the gut. The gut is the source.
That is a crucial distinction. It's not bad luck you have two cancers. This is stage 5 colon cancer.
Exactly. And that has huge implications for treatment and prognosis.
All right, let's pivot. We've covered the anatomy of the right versus left. Now I want to talk about the who and the how, the genetics. This feels like the area where people get really bogged down in acronyms. FAP, HNPCC, Lynch. Help us straighten all this out.
It is a highly tested area, but it's also just critical for saving lives because these are the hereditary syndromes. If you identify one person in a family with this, you can screen and save their relatives.
Yeah.
You can prevent cancer.
So we need to distinguish between two main players.
The two big ones you have to know are FAP and Lynch syndrome.
Let's start with FAP, familial adenomatous polyposis. Even the name just sounds crowded.
It is crowded. The visual you need to have in your head for FAP is a colon that is literally carpeted with polyps.
Not just a few.
Now, we aren't talking about 5 or 10 polyps like you might find in the standard screening colonoscopy. We are talking about hundreds, usually thousands.
Thousands. That's hard to even imagine.
It is. If you look at an endoscopic picture of a patient with FAP, you can barely see the normal pink lining of the colon because it is just bump after bump after bump. It looks like a cobblestone street. There's no normal tissue left.
Wow. And what causes this? What is the broken blueprint here?
This is caused by a germline mutation in the APC gene on chromosome 5.
APC. Okay, easy enough to remember. And what is the risk here? If someone has this gene and that carpet of polyps, is cancer just a possibility? Or is it?
It is 100%.
100%. You don't hear that number often in medicine.
No. If left untreated, a patient with FAP will develop colon cancer. It's not a matter of if, but when. And the when is usually at a young age, often in their 30s or even their 20s.
And why is it so certain?
It's a statistical certainty because when you have thousands of polyps, you have thousands of chances for one of them to make that malignant transformation. Eventually, one of them will turn bad.
100% is a truly sobering number.
Which is why the management is so aggressive. We recommend a prophylactic colectomy.
So you remove the entire colon before the cancer can even start.
You have to. You cannot possibly monitor 5,000 polyps. You can't biopsy them all. So you have to remove the entire field of risk.
Now, the notes mention some extra features. Associated syndromes. I see Gardner and Turcot. How do these fit into the FAP picture?
Think of these as FAP+. These are variations of FAP where the APC mutation causes issues outside of the gut as well.
Okay, FAP+. Let's start with Gardner syndrome.
Gardner syndrome is essentially FAP plus a collection of other extraintestinal growths. But the classic one to remember is osteomas.
Osteomas are bone growths.
Yes, benign bone tumors. They often appear on the skull or the mandible, the jaw. So you might have a patient who goes to the dentist for a routine x-ray, and the dentist sees these extra little bone lumps in the jaw.
And if that patient also has a family history of colon trouble or has had polyps himself?
You connect the dots. The dentist might actually be the one to suspect Gardner syndrome and trigger the referral. It's a great clinical pearl.
That is fascinating. Okay, and what about Turcot syndrome?
Turcot syndrome is FAP plus brain tumors.
That is a terrifying combination, the gut and the brain.
It is. It's typically associated with medulloblastomas or glioblastomas in the brain. The mnemonic a lot of people use is a turban for Turcot.
A turban on your head.
Right, you wear a turban on your head. Hone, head, eagle, brain tumor. It's a bit silly, but it works.
That works. Turban, Turco, equals brain. And one more detail for FAP, it is also associated with desmoid tumors, right? What are those?
Yes, these are fibrous tumors that can occur in the abdomen, often in the surgical scars after a colectomy. They aren't cancer in the sense of metastasizing to other organs, but they can be very locally aggressive and cause a lot of problems by invading nearby structures.
Okay, so FAP is about quantity. It's a numbers game. Thousands of polyps, 100% risk. Now let's flip to the other side of the coin, Lynch syndrome. I know this used to be called HNPCC.
Right. Hereditary non-polyposis colorectal cancer. And the name actually tells you the whole story, the whole contrast.
Non-polyposis. So no carpet of polyps.
Exactly. Unlike FAP, Lynch syndrome patients have few polyps. They might just have a handful, maybe only 1 or 2. But the danger is just as high, if not more insidious, because you don't have that obvious visual warning of 1,000 bumps.
So how does the cancer start if there aren't many polyps? What's the mechanism?
It's a mechanic failure. The mutation is in the DNA mismatch repair genes.
Mismatch repair. That sounds like a spell check function for your DNA.
That is exactly what it is. It's a perfect analogy. Think of your DNA replication like typing out a massive manuscript. Every single time your cells divide, they have to retype the entire 3 billion-letter genetic code.
And sometimes they're going to make typos.
They're going to make typos. A G goes where a T should be. Mismatch repair enzymes are the proofreaders. They scan the new document, they find the typo, and they fix it.
So in Lynch syndrome?
The proofreader's on strike. Or they're asleep at the wheel. The typos don't get fixed. We call this microsatellite instability.
So the typos, the mutations just accumulate.
They accumulate at an incredible rate. So even though you don't have many polyps, the few you do have can transform from benign to malignant at lightning speed.
So it's quality versus quantity. FAP is a quantity problem. Too many lottery tickets. Lynch is a quality problem. Every ticket is almost a guaranteed winner.
That is a perfect way to conceptualize it. I'm going to steal that one.
And because of this rapid transformation, how does Lynch present clinically?
It presents early, often in patients in their 30s or 40s, And interestingly, it has a predilection for the right side of the colon.
Right-sided again. So this young patient might show up with that subtle iron deficiency anemia we talked about at the beginning.
Correct. But here is the big exam trap and the major clinical red flag for Lynch syndrome. It is very strongly associated with endometrial cancer in women.
Endometrial cancer, the lining of the uterus.
Yes. Lynch syndrome is a systemic genetic defect. The broken spell checker doesn't just affect the colon. It strongly affects the uterus. In fact, for some women with a Lynch syndrome mutation, endometrial cancer is the sentinel cancer. It's the first one to appear even before the colon cancer shows up.
That is absolutely critical to know. So if we are doing our pattern recognition, if I see a young patient, maybe in their 30s or 40s, with a new diagnosis of colon cancer,
Right.
and they mentioned their mom had uterine cancer and their aunt had uterine cancer and maybe a cousin had ovarian cancer.
That constellation young patient plus early onset cancer plus strong family history plus endometrial or ovarian issues, that should make you scream Lynch syndrome. You need to test them.
Okay, so FAP is the carpet of polyps, the APC mutation. Lynch is the broken spell checker, the mismatch repair problem with that strong endometrial connection.
Perfect summary. You got it.
All right, moving on to segment 3, the rules of engagement. We've identified the cancer. Now we have to stage it and plan the battle.
Exactly. Staging is how we determine the battle plan. It tells us how far the disease has spread and what tools we need to use.
First off, diagnosing. We already said colonoscopy is the gold standard. You have to see it and you have to biopsy it. But what about blood tests? I hear a lot about CEA, carcinoembryonic antigen. Can't I just get a blood test to see if I have colon cancer?
This is the classic trap.
Ugh.
And it's a dangerous one. CEA is a useful tumor marker, but, and this is a huge but, it is used for monitoring recurrence, not for screening.
Okay, explain that distinction. Why can't I use it for screening?
Because a tumor could be present, even a large one, with a completely normal CEA level.
Right.
It's just not sensitive enough to pick up every cancer. And on the flip side, CEA can be elevated by things that aren't cancer, like smoking or inflammatory bowel disease.
So a normal CEA does not rule out cancer.
It absolutely does not. If a patient has symptoms like bleeding or anemia or a change in bowel habits, do not be reassured by a normal lab value. You still need to look inside with a scope.
Okay, that's a dangerous trap to fall into. Oh, your blood work is fine. Don't worry about that bleeding. That's bad advice.
Terrible advice. Think of CEA as a smoke detector for after the fire's already out. If we remove your cancer and your CEA drops down to 0, we watch that number over time. If it starts creeping up 6 months or a year later, that tells us the fire might be back.
It helps you catch a recurrence earlier.
Exactly. Monitor, don't screen.
Got it. Monitor, don't screen. Now let's talk staging logic. When we look at a pathology report after the surgery, we see all these letters and numbers, T1, T2, T3. What are we actually measuring? The size of the tumor in centimeters.
You know, in many other cancers, like breast cancer or lung cancer, the size of the tumor in centimeters matters a lot. In the GI tract, it's not about size, it's about depth.
Depth.
It's all about how deep the tumor has burrowed into the wall of the gut. You have to think of it like a drill bit.
Okay, so remind us of the layers of the wall.
Imagine the wall of the colon is like a sandwich or a wall in a house. The very inner layer is the mucosa. Then you have the submucosa, then a thick muscle layer called the muscularis propria, and then the fatty tissue outside.
So how does the T staging map to that?
T1 means the tumor has just gotten into the submucosa. T2 means it's dug deeper into the muscle, the muscularis propria. T3 means it's gone all the way through the muscle and into the fat around the colon. And T4 means it's broken out completely and is now invading adjacent organs.
The deeper the drill bit goes, the worse the prognosis.
Correct. But there's an older parallel system called Duke's classification. It's a bit simpler and sometimes helps visualize the big picture.
How does that one work?
Duke's A is superficial, just in the wall. Duke's B means it's gone through the wall. Duke's C means lymph nodes are involved. And Duke's D is distant metastasis.
The pivot point there seems to be the lymph nodes. Duke's C.
That is the most critical pivot point for treatment. Node positivity significantly worsens the prognosis. And here's the rule you absolutely need to know. If lymph nodes are involved, we call it stage 3.
And why does that matter so much for the patient? Does it actually change the treatment?
Drastically.
Yeah.
Because stage 3 is the trigger for adjuvant chemotherapy.
Okay, explain the logic there. Why do nodes mean chemo?
If the nodes are clean, so stage 2 disease surgery alone is often curative, we cut it out and you are done. We watch you. But once that cancer hits the lymph nodes, that means the cancer cells have gotten into the lymphatic highway.
They could be anywhere in the body.
They could be anywhere. So you need systemic treatment chemotherapy to go through the whole body and mop up any microscopic cells that might be floating around, waiting to set up shop somewhere else.
That's a huge distinction. Surgery alone versus surgery plus chemo.
It is a massive difference in treatment burden and side effects. And here is the trap that examiners love to set. Imagine a tumor that has dug really deep. It's a T3 or even a T4. It is punched all the way through the muscle. But the lymph nodes are all negative. Is that stage 3?
It feels like it should be bad because it's so deep, but you just said nodes define stage 3.
So no. Correct. Muscularis invasion without nodes is stage 2. Do not confuse this with stage 3. A deep T4 with no nodes is still stage 2. It has a better prognosis and usually does not require chemo, whereas even a tiny T1 tumor that has reached a single lymph node is stage 3 and needs chemo.
The nodes are everything.
The nodes are everything.
At stage 4, what defines that?
Stage 4 is simple. It means distant metastasis. The cancer is spread to another organ, and as we discussed, for colon cancer, that's usually the liver.
Okay, so depth determines the T stage, but nodes determine if you get chemo.
Simple as that. That's the core logic.
We are making great progress. We've cleared the colon. Now we are descending further down into the pelvis. Segment 4, the rectum.
The rectum. This is where things get tricky and the rules start to change.
You said earlier that anatomy determines destiny. How does the rectum's anatomy differ from the colon we just spent so much time on?
The most important difference is what I call the coat. The colon, for the most part, is wrapped in a smooth, slippery outer lining called the serosa. It's like a protective raincoat.
A raincoat. Okay.
I like that.
It helps to keep the cancer contained to some extent. But the lower third of the rectum, it loses the raincoat. It has no serosa.
It's naked.
It's just sitting there in the very crowded, very tight space of the bony pelvis, surrounded by the bladder, the prostate in men or the vagina in women, the sacrum, major nerves, and blood vessels. And it lacks that protective outer coat.
So if a tumor starts growing outward in the lower rectum,
There is no barrier. Local spread is much, much more common and much easier. It can invade those surrounding pelvic structures very quickly because there is literally nothing stopping it.
that sounds incredibly difficult to manage surgically if it's sticking to everything in that crowded space.
It is. It's a very dangerous neighborhood for a tumor to be in. And that one anatomical fact, the missing serosa, drives the entire difference in management.
How so?
In colon cancer, we almost always do surgery first. We just cut it out. But in rectal cancer, especially locally advanced disease like stage 2 or stage 3, we often use preoperative chemoradiation. So you radiate it and give chemo before you ever touch it with a knife.
Yes. We call it neoadjuvant therapy. The goal is to shrink the tumor, to pull it back from those surrounding structures, and to sterilize the field, essentially. We want to downstage it before we even attempt to remove it.
That makes total sense. You shrink the target, you create some space, and then you cut it out. And what is the surgery itself called? I see the acronym TME in the notes.
TME stands for total mesorectal excision. This is the gold standard surgical principle for a rectal cancer. It revolutionized the field.
Okay, explain the envelope concept that's so important here.
The rectum is surrounded by a discrete layer of fat called the mesorectum. That fat contains all the lymph nodes and the blood supply for that segment of bowel. TME means removing the rectum and that entire fatty envelope as one pristine, intact package.
Like removing a letter while it's still sealed inside its envelope. You don't want to tear the envelope open.
That's the perfect analogy. If you tear that envelope during surgery, you risk spilling cancer cells back into the pelvis, which leads to local recurrence. TME reduced recurrence rates from 30 or 40% down to less than 5%. It's all about respecting that package.
Now, for the patient, I think the scariest part of rectal surgery is often the question of the bag. Will I need a permanent colostomy? How do you make that decision?
It is a profound, life-altering decision, and it comes down to a simple metric: distance from the anal verge. Basically, how close is the bottom edge of the tumor to the exit?
What's the cutoff number?
The general rule of thumb is 2 centimeters.
That is a tiny margin. That's less than an inch.
It is. If the tumor is less than 2 centimeters from the anal verge, it is either invading or sitting right on top of the sphincter muscles, the complex muscles that allow you to control your bowels.
And you can't save the muscle if the tumor's in it or right next to it.
Correct. You cannot save the sphincter without risking leaving cancer behind. It's not oncologically safe. So for those very low tumors, we have to perform an APR, an abdominoperineal resection.
And what does that entail?
We remove the rectum, we remove the anus and the sphincters, and we sew the bottom shut. The patient gets a permanent colostomy on their abdomen.
That's a massive life change. And if the tumor is higher up?
If it is higher up, say 5 or 10 centimeters from the verge, we can often perform a low anterior resection, or LAR. We remove the tumor, but we can reconnect the remaining colon down to the remaining rectal stump or even to the anus itself. Continuity is preserved. No permanent bag.
So literally, a difference of a few centimeters determines if you wake up from surgery with a permanent bag or not.
Biology respects boundaries, and here geometry dictates quality of life. That's why staging with an MRI of the pelvis is so absolutely vital for these cancers. We need to know exactly where that tumor sits, down to the millimeter.
Segment 5, the final frontier. We are at the end of the line, the anal canal.
We have reached the end of the tract, the final 2 or 3 centimeters.
And you said there is a twist here, a major plot twist in the biology.
The twist is that we are changing tissue types. We are no longer dealing with gut tissue. We're crossing a major histological border.
What do you mean by that?
The colon and the rectum are lined with glandular cells, what we call columnar epithelium. That's why we get adenocarcinoma, cancer of the glands. But the anal canal is where that lining transitions to become more like skin. It's lined with squamous cells.
So the cancer that forms here isn't adenocarcinoma?
No, it is squamous cell carcinoma, SCC, a completely different type of cancer.
And if it's a different type of cancer, does that mean the risk factors are different too?
Drastically different. The primary driver for anal canal SCC is HPV infection, human papillomavirus.
HPV. That sounds much more like cervical cancer than it does colon cancer.
It is almost identical to cervical cancer biology. It's the same virus, the same mechanism of cancer formation. And because the biology is completely different, the treatment is completely reversed. This is probably the biggest exam trap in all of lower GI oncology.
Okay, hit me with the trap. What's the big mistake people make?
We just spent all this time talking about surgery, colectomy, TME, APR. Surgery is the absolute cornerstone of treating colon and rectal cancer. But for anal canal squamous cell carcinoma, surgery is not the primary treatment.
Wait, you don't cut it out at all?
We do not. Not first, anyway. The standard of care, the first-line treatment, is chemoradiation. It's famously called the Nigro protocol.
Why? Why not just cut it out like all the others? It seems so straightforward.
Because cutting it out would require that APR surgery we just talked about, removing the sphincter and giving the patient a permanent colostomy for the rest of their life. But it turns out that squamous cell carcinoma is incredibly sensitive to chemo and radiation. It just melts away.
It melts.
It responds beautifully. So we give the Nigro protocol, which is a combination of chemotherapy and radiation therapy given together, and in the vast majority of cases, the tumor disappears completely. The patient keeps their sphincter. They keep their normal function. They keep their quality of life.
So surgery is only a backup plan if the chemo and radiation don't work.
Exactly. We call it salvage surgery. If we radiate it and we check back 6 months later and there's still cancer left, what we call residual disease, then and only then do we operate. But for most patients, the knife is the absolute last resort, not the first.
That is a crucial distinction. Let me just recap that because it feels so vital.
Please do.
Rectum adenocarcinoma surgery, TME, is the central treatment.
Correct.
Anal canal squamous cell chemoradiation, Nigro protocol, is the central treatment.
If you remember nothing else from the pelvic section of this deep dive, remember that reversal. It saves sphincters and it saves lives.
This has been an incredible journey. We've gone from the silent bleed of the right colon to the pencil stools of the left, through the carpet of FAP and the hidden mutations of Lynch, down to the naked rectum, and finally the squamous cells of the anal canal. Let's try to bring this all together. What is the meta pattern here? What's the one big idea?
The meta pattern is that location defines presentation and management. It all comes back to anatomy. Let's just quickly run through the big 5 pillars we covered today.
Okay, number 1.
Right versus left. The anatomy dictates the symptoms. The wide right side gives you anemia, it's silent. The narrow left side gives you obstruction, it's loud.
Number 2.
Genetics. It's quantity versus quality. FAP is a carpet of thousands of polyps from the APC gene. Lynch is a broken spell checker from a mismatch repair mutation.
Number 3.
Staging logic. Depth, the T stage, tells you how bad it is locally, but it's the nodes, stage 3, that tell you if you need chemo.
Number 4.
The liver. It's the magnet for metastasis because of the portal vein. It's the first stop for blood from the gut.
And number 5. The grand finale.
The pelvic split. It's a tale of 2 different cancers. Rectal adenocarcinoma gets surgery, specifically TME. Anal squamous cell carcinoma gets chemoradiation, the Nigro protocol.
It really does become so much simpler when you map it out anatomically. It's not just a random list of symptoms and treatments to memorize.
No, it's a story. The body has a logic. If you respect the anatomy, the blood flow, the muscle layers, the cell types, the medicine just follows naturally.
I love that phrase you used earlier. Biology respects boundaries. And speaking of boundaries, we are going to cross a big one in our next deep dive. We're leaving the hollow tubes of the gut and moving into the solid organs.
Yes. Next up is the Hepatopancreatic Oncology Masterclass. We are going to tackle the liver and the pancreas.
The heavyweights.
Two of the most complex and, frankly, unforgiving organs in the body. The surgery is harder, the biology is more aggressive, and the stakes for the patient are incredibly high.
I can't wait to decode that one. But for now, just take a second to visualize that decision tree we built today. Next time you hear iron deficiency anemia in an older patient, pause and think. Right, colon.
And always, always check the liver.
Always check the liver. Thanks for diving in with us.
Until next time.